Ladies and gentlemen, welcome to Mask Ultrasound Zoom meeting. And we are so privileged this afternoon to have one of our distinguished guests from a beautiful country of Iran. And I know she is very popular. And in fact, she has just released her latest book on injection techniques that includes a lot of different structures in our body. He is a pain specialist and is involved in so many teaching activities in her country and also in other parts of the world. And I am so happy to invite her today. And I know she will be able to complete all these contributions that has to do with pain management, and especially with chronic pain that sometimes we all struggle to encounter. And I am so glad to and have the honor to introduce to you Dr. Helen Gharaei. Okay, I hope I just pronounce it the way I can actually manage to pronounce it, because the Iranian way is difficult for me. According to Helen, I did not really get it right. But this is the way I can pronounce it. Dr. Helen Gharaei. So before we begin, let us just pause for a moment for a short prayer, and then off we go to her lecture. So let's pray. Heavenly Father, we thank you for this beautiful day. We thank you for life. We thank you for the privilege of learning new things, especially today as Dr. Helen Gharaei of Iran will share to us her expertise and her knowledge that can be of help to our patients. Can you bless her, protect her from any problems and any infections that might go along the way. Keep us safe wherever we are. In Jesus' name we pray. Amen. So Dr. Helen Gharaei, the pride of Iran, on the ultrasound guided injection in pelvic entrapment neuropathy. So please go ahead, Dr. Helen.
Thank you. Thank you for your introduction. And I'm very happy to see my colleagues and friends in the Philippines. I will talk about ultrasound guide injection in pelvic entrapment neuropathy. This is not very common like other chronic pain, but I want to give you a view and could manage your patient in clinic. Pelvic neuropathy is an important group of disorder cause pelvic pain syndrome. There is various causes for pelvic neuropathy, including compression of the nerve, repetitive microtrauma, injury, even injection, inflammation, and surgical incision and post-operative scarring. This is very important. Many patients come to you with scarring and complain from pain in the abdomen, pubic region, pelvic region, and you have to think about entrapment neuropathy of the pelvic. Clinically, patients may present with paresthesia, dysaesthesia, allodynia, dysreflexia, dyspareunia, and dysfunction of the muscle that innervate by this nerve. And you have to think about them. When a patient comes to you and complain from neuropathic pain in pelvic region, in a lower abdomen, you have to think about pelvic entrapment neuropathy. Diagnostic include clinical history and physical examination. If you know this syndrome, you can think about it. The most important part of diagnosis is history taking. You have to have a good history taking from your patient. If she has a surgery before, if she has a trauma, if she or he use a tight clothes, this is very important. If he or she is a sportsman and do bicycling, they will give you a view about pelvic neuropathy. I will talk about them step by step in my PowerPoint. Many of these patients may require investigation to accurately identify the affected nerve, including MRI or diagnostic nerve block, because this nerve has many overlap. So sometimes it needs that you block them step by step. Really, pelvic pain is very disabling. It affects many women and men around the world. Maybe occur after an inciting event, or it may be idiopathic. Although many of the people suffer from this pain, most of them remain undiagnosed, even following multiple physician visits. This is very important. Please think about this pain syndrome. A common cause of chronic pelvic neuropathy include femoral, genitofemoral, ilioinguinal, iliohypogastric, pudendal, pleural, and most of you, especially anesthesiologists, think about femoral obstructive nerve, sciatic nerve block, but you as a pain specialist must think about neuropathy of this nerve. This is different. Neuropathy of the femoral, neuropathy of the obstructive, neuropathy of the sciatic nerve, all of them may have chronic pain, and the patient may come to you with chronic disabling pain from neuropathy of this nerve. Cutaneous nerve entrapment plays an important role in neuropathic pain syndrome. Fortunately, due to advancement of ultrasound technology, the cutaneous nerve can be visualized by high-resolution ultrasound. As the cutaneous nerve course superficially in subcutaneous layer, they are vulnerable to entrapment or collateral damage in traumatic insult. Nerve block are imperative for diagnosis of neuropathic pain. I will talk about anterior pelvic nerve entrapment and posterior pelvic nerve entrapment, and give you a view with case presentation and ultrasound view from my new book. And you are the first one who see this because it will publish soon. Yes. The first nerve is ilioinguinal iliohypogastric neuropathy. This is uncommon, but may be caused by retroperitoneal tumor or surgical trauma, especially after nephrectomy, cesarean section, hysterectomy, and inguinal hernia repair. Many patients refer to me after cesarean section, hernia repair, and complain from neuropathy of this nerve. Please think about them. Nerve injury may cause by a stretching of abdominal wall during surgery. Because of these 2 days, laparoscopic surgery, robotic surgery are more common to prevent the stretching of the abdominal wall. A stretching of the abdominal wall may lead to neuropathy, chronic pain, and neuropathy of this nerve. This nerve, usually not only this nerve, all of this nerve in the abdominal wall entrap between facial layer of the abdominal wall. Even pregnancy with stretching of the abdominal wall may cause neuropathy of this nerve, which finished and end after delivery. This patient complain of chronic abdominal pain, suprapubic pain, and groin pain, dysesthesia, hyperesthesia in nerve distribution, and trigger point in abdominal wall. Please think about trigger point. Do a good physical examination. You may find trigger point on abdominal wall of your patient. And the injection in this trigger point and injection in the nerve will relieve the pain, which maybe patients suffer from this pain for many, many years. You know, this nerve, ilioinguinal iliohypogastric, you can see here, origin from L1 and L2, and then from lateral. The psoas muscle is very important because most of this nerve from the anterior and posterior of the pelvic come past lateral to psoas nerve, and this nerve comes anterior to, this is quadratus lumboris, and then come here. This is transverse abdominis muscle, and transverse abdominis muscle run around the abdomen. These nerves originate from spine, and it become cutaneous and between the fascia, and this is the site that you can block the nerve. Not all the time you can use the classic technique. Sometimes there is a tumor, peritoneal tumor here, and may you have entrapment neuropathy of the here, so the block must be done more. upper, more proximal, not just here in inguinal canal. Okay, always think about this. This is a case presentation of this patient. For example, a female comes to you with suprapubic and left lower quadrant pain with bladder problem. Always think about bladder problem in this entrapment neuropathy because it originates from L1 and L2. So this patient suffers from nocturia and dyspareunia. And this symptom developed after even laparoscopic surgery, 8 months prior to present to you. Patient complained from left lower quadrant pain. Localized, this is very important, localized to on her laparoscopic port site. Do physical examination. You may find a trigger point at the laparoscopic site. Okay? When you do physical examination, you see that there is a site of exacerbation of the pain at the scar. They perform ilioinguinal iliohypogastric nerve block and the pain relief and even urinary complaint relief. So when a patient like this refer to you, think to ilioinguinal iliohypogastric nerve entrapment. This is the injection technique. You can draw a line from umbilicus to anterior superior iliac spine and divide it in 3 spaces. Intern here, put probe here, linear probe here in lateral 1/3 and enter your needle in plane from lateral, from here toward the muscle. And please notice that abdominal wall is very thin. So a simple needle like this is enough. It is not necessary to use a spinal needle as is common. So these are from my new book. This is my logo. If you see this is from my book. No one see these pictures before. You will see this. This is very important that you see acoustic shadow of anterior superior iliac spine. Then you will look at this muscle layer. This is muscle layer, and look at for this artery, circumflex artery, and be careful, don't inject into this artery. This is my painting. You know, I'm a painter. Okay, you see this is external oblique, internal oblique, and transverse abdominis. And this here is the site of the nerve and vessel. You can enter your needle in plane from here, just between fascia. If you couldn't see the nerve, it's not important. Just inject between this fascia and see that this fascia open in the ultrasound screen. It's better if you are novice, first inject a test dose and see the distribution of your drug here. You can use Doppler and then inject your drug. This is not a dangerous drug. Just be careful, don't enter your needle into the abdomen. The second nerve, which is very common, is myalgia paresthetica. This is due to neuropathy of lateral femoral cutaneous nerve by entrapment or injury. Very common in my clinic. The symptom is burning, tingling. When a person complains from burning, think about neuropathic pain. This is very important in my experience. Numbness and pain in proximal and anterolateral portion of the thigh. Anterolateral portion of the thigh is very important to differential diagnosis. Sometimes maybe you think that this is due to lumbar spine problem. I had a patient with failed back surgery syndrome who had a spine surgery months ago and referred to me with pain. And I first think that this is a radiculopathy. Then I noticed, no, there is pain and numbness and burning in anterolateral aspect of the thigh. So with a simple injection, relieve the pain. And it was not necessary to do any procedure on the spine. So always when a patient comes to you with tingling, burning in anterolateral portion of the thigh, think about lateral femoral cutaneous nerve entrapment neuropathy. In practice, I always choose first the most simple injection and non-invasive injection. And then step by step, I go to more invasive procedure, especially in lumbar spine. Peripheral procedure are non-invasive and done very simply. And if a lateral femoral cutaneous nerve injection diagnostic block could relieve your patient pain, this is enough, not necessary to do more invasive procedure. If posterior branch is involved, patient may complain of buttock pain. Symptom is often aggravated by weight bearing, hip extension, or prone position. This is very important. Cause of neuropathy always is microtrauma, repetitive trauma, especially in driver. They have this complaint from this neuropathy. Tight closing is very important, even in children, and will cause this neuropathy. Even lumbar support for spine surgery may cause this symptom. I had a patient that comes to me with pain, and the pain was because of this lumbar support. It entrapped this lateral femoral cutaneous nerve. Maybe pregnancy caused to this syndrome, or pelvic surgery, diabetes. Many patients with diabetes comes in the lateral, contralateral type pain, suffer from this neuropathy. I had many patients with diabetes, and it was because of neuropathy of this syndrome. And you see, this is originates from L2, L3, and comes to this course. Sartorius is very important because it could help you for ultrasound injection. Nerve comes here, and most of the time entrap here. And this is a case. A 22 years old, present with complaint of paresthesia, burning, and pain in left lateral aspect of thigh, and diagnosed with myalgia paresthetica. They gave her gabapentin and increased the dosage, and as without any relief. Then they choose diagnostic block. So this is a ladder treatment. You must start from the less invasive, conservative treatment, medication, then go to diagnostic block. Okay. Then the patient responded to diagnostic block, but it was short-lived. So they used pars RF of the lateral femoral cutaneous nerve with dramatic result. When the patient had short-lived response, or it refractory to your block, you can choose pars RF. Pars RF increase the duration of the pain relief, and it's a very good choice. Some patients use cryo. This is injection. You put your linear probe. This is anterior superior iliac spine, a little medial, and inferiorly. Okay, and try to see acoustic shadow of anterior superior iliac spine and the large sartorius muscle. This is fascial lata, and this is the nerve, very superficial. Okay, anterior needle here from in plane until receive here and inject, and see this is again an interfacial block. Open this fascia. The second nerve is femoral neuropathy. Femoral neuropathy may cause chronic entrapment neuropathy, chronic pain in the patient. This patient may suffer from a surgical injury, tumor, maybe due to childbirth or prolonged labor. Prolonged labor, especially in lithotomy position, I had this patient, will cause femoral neuropathy, even pelvic fracture, even blunt trauma, and even abdominal or vaginal hysterectomy, even laparoscopy may cause to femoral neuropathy. So if a patient referred to you with numbness, paresthesia in iliac fossa, in inguinal region, anterior thigh, medial calf, foot, grade 2, ipsilateral knee weakness, in severe case, you see weakness and atrophy of quadriceps muscles. This is one nerve that you will see the weakness because it is sensory and motor. So look at the weakness. This nerve originates from L2, L3, L4, again psoas muscle, and comes here. Okay, in past the medial inguinal ligament, and it's accompanied with femoral and vein, femoral artery and vein, And this is very important. I put this my picture book. This is anterior superior iliac spine. This is iliopsoas notch. This is iliopectorinus eminence. This is pubics, and this is a site that femoral nerve may had entrapment. So when you use femoral block, maybe the entrapment is upper. So think about entrapment at this site and inject there. Injection of femoral nerve is very easy because you can see femoral vessel. Put your probe here. You can touch the pulse of the femoral. This is very easy. Under inguinal ligament, and you will see the femoral with help of pulse. Femoral vein and artery, and femoral nerve is here in this triangular space, lateral to the vessel, and you can inject under this fascia. Okay. And this case presentation. Look at this. This is a man complaining of right thigh pain. Any patient with thigh pain, think about femoral neuropathy. And weakness. Look at this weakness. And begin suddenly. There is no history of medication, trauma, or medical problem. They did CT, laboratory result, all of them are normal. Most of these patients with entrapment neuropathy undergone many lab and imaging study, and all of them are normal. And they are very agitated because they told you all of them is normal. So why I still have pain? The pain subsides after 1 month, but weakness of quadriceps muscle progress and atrophy of thigh. With atrophy of thigh, sensory examination to touch and vibration is normal. So the diagnosis is femoral neuropathy, and this patient responds to femoral block. The second nerve is obturator neuropathy. Maybe you are not familiar with this neuropathy, but we have obturator neuropathy, especially in athletes, in sportsmen and women. And it causes repetitive microtrauma or facial entrapment, prolonged acute hip flexion, such as in urologic and gynecologic surgery in lithotomy position. Lithotomy position causes many entrapment in anterior thigh, anterior pelvic. And maybe cause obturator palsy. Orthopedic surgery with semen extrusion from hip during arthroplasty may cause obturator neuropathy. And even laparoscopy inguinal surgery may cause obturator neuropathy. They refer to you with groin pain, hip pain. This is important, hip pain, and pain in medial part of the thigh. When patient come with hip pain and medial of the thigh, think to obturator neuropathy. And worsen with extension. Pain may also associate with weakness of leg adductor and sensory loss in medial thigh. This is the point that you must think about obturator neuropathy. You have weakness of leg adductor. You must do a good physical examination. Symptom is numbness, paresthesia on medial aspect of the thigh, and weakness in adduction of the thigh. Patient could present with posture and gait problem due to loss of adduction. So look at the gait problem. Again, this is obturator nerve, origin from L2, L3, and L4. And this is a beautiful video of passing of the nerve here. You can see here, this is external obturator, and these are adductor. The point of injection is in proximal part and in distal part. Depend on your experience. And it's very easily done with the help of ultrasound, and show you this in ultrasound screen. I think this is the first time that you will see these pictures because there isn't such good view in the internet. Put your probe here, linear probe near pubis. You will see pectineus muscle. This is acoustic shadow of pubic, always help you. This is pectineus muscle, very beautiful. And under it is obturator excess. Nerve is here. You can block nerve here in proximal approach. In distal approach, move your probe a little inferior and medially. Okay. Then you can see again pubis and adductor muscle, longus, brevis, and magnus. You can block anterior branch here between longus and brevis, and posterior branch here between brevis and magnus. And you had very good result. I had a patient a footballist and complain from this pain and respond very good to this injection. This is a case presentation of obturator neuropathy. A woman present with some symptomatic intramural tumor and underwent laparotomy, and total hysterectomy is done for her with general anesthesia. There was no problem during the procedure and after that. But when patient, 2 hours after procedure, when patient wants to stand, she noticed loss of strength when adduct both legs and could not walk without help. So this is the kind of obturator neuropathy after the surgery. And this, the other nerve is genitofemoral neuralgia. This is from entrapment, again wearing tight clothes. This is a fashion, but it's not good. Or trauma during the surgery, herniorrhaphy. It causes pain in lower part of abdomen that refer to groin or inner thigh. The symptom may include pain, paresthesia, and burning sensation again in lower abdomen to medial aspect of thigh. Pain radiate to labia major and mons pubis. This is very important. Women refer to you with this pain. And most of the women don't like to discuss about their genital pain, but they are, you have to ask them. And diagnosis is challenging because there is overlap between this nerve and ilioinguinal iliohypogastric. So you may need to inject step by step. I had a patient with pain, and then I think about another nerve, even lateral femoral cutaneous nerve, and the patient didn't respond to diagnostic block. Then I blocked this nerve and respond to this block. This is genitofemoral, very beautiful view of genitofemoral. It comes from here, and again psoas muscle. Look at the psoas muscle, and it gives branches here in inguinal canal. For more information about genitofemoral neuralgia, a woman comes to your clinic with burning and itching in right labium. For 2 years, she has had vaginal delivery, and she had a Crohn problem. When a person has a chronic disease, all the physicians confused and think all the symptom is related to that chronic disease. No. This patient had chronic disease, and they asked her to do there was no history of inflammation, infection, or neoplastic disease. During examination, there was burning sensation in labia and hyperesthesia and allodynia. So they think about genitofemoral neuralgia. So it must not be due to Crohn. This is another problem. This is very good, beautiful picture. You didn't see this in internet. For this block, again, put your probe, linear probe, on near to pubis and femoral artery. You can touch the femoral artery. Put your probe here, and then you can see the parts of the femoral artery, and more medial and up to pubis, more medial and up to femoral. So this is very important. You can see this. This is testicular artery, and you can see this honeycomb shape of testicle. It's a very beautiful view. And this is a longitudinal view. This is external iliac, the femoral artery, then external iliac. And you can see again, this is a spermatic cord and testicular artery. For injection, I prefer out of plan technique. And then you need here under the fascia of the cord and inject. The dramatic result in women, you have a round ligament. In men, you have a spermatic cord. But this is very similar. We have also injury to superior gluteal nerve. This is not very common. We didn't hear about it. But the patient comes to you with gluteal medius limp and Trendelenburg and Wadering gait. This is very important for you. Any patient comes with this symptom and neuropathic pain, think about entrapment of this nerve. May cause due to compression by the piriformis muscle and may result to back pain, weakness, and adduction that affect the hip and tenderness even in greater sciatic notch. Superior gluteal neuropathy is uncommon and may cause as a result of blunt trauma, pelvic fracture, or any iatrogenic cause. Buttock injection, over lifting and twisting injury, falling buttock, or poorly placed injection, perioperative injection, arthroplasty of the hip may cause superior gluteal nerve entrapment neuropathy. So when a patient has in surgery in this place, around the buttock and hip, think about this syndrome. Because a separate course of superior gluteal nerve above the piriformis muscle, injury to this nerve are usually isolated. This is the only nerve that passes up to piriformis muscle. Other entrapment neuropathy happened under the piriformis muscle. So it's very easy that you in ultrasound screen you search up to piriformis muscle. Piriformis is very easy seen in ultrasound. They refer with pain in lower back, buttock, and radiation to foot, pain with prolonged sitting, leaning forward or twisting to lateral side, pain increase with standing and walking, decrease with sitting, decrease with sitting. This is very important, differentiated from pudendal entrapment. And tender point lateral to posterior superior iliac spine. This is nerve. This is the piriformis, greater trochanter. Here is piriformis, and this is superior gluteal nerve. Fortunately, there is an artery near it, and it would be helpful for finding this nerve on ultrasound screen. Other nerve pass under the piriformis. Okay. And this is my beautiful picture. You can see here gluteus maximus, gluteus medius, and gluteus minimus. Nerve pass between gluteus medius and gluteus medius, and you will see the artery here. So inject here in plane, and you will find a good result. And pudendal neuralgia. Maybe most of you hear about pudendal neuralgia. Again, in this neuralgia, maybe to fall, maybe to entrapment, and maybe to thickening sacrotuberous ligament. Nerve may be affected because of the previous trauma of falling or previous surgery. Injury in ischial-anal fossa may be due to prior hemorrhoid surgery, proctolectomy, and maybe due to birth trauma. Cycling. Cycling is a good point. Some patients refer to with cycling and complain from genital pain. Think about pudendal entrapment. I had a patient maybe due to tumor or trauma in symphysis pubis, because pudendal nerve has a long course. It may affect during its course in upper or in lower part. And repair of prolapse of pelvic organ, which is common in women, is the most common cause of pudendal neuralgia. And even vaginal delivery, because of the effect of fetal head, may cause neuralgia of the pudendal. Even chronic constipation. It's very, very interesting. A patient with chronic constipation may have pudendal neuralgia. Excessive cycling, as I told you before, may cause fibrosis in sacrospinous and sacrotuberous, and pressure on the nerve. Prolonged sitting in driver in patient who work with computer may cause this syndrome. Patient refer with pain and numbness in perineal region. and the dysfunction of the muscle in the area of genital rectum and terminal urinary tract may cause vulvodynia, may cause dyspareunia, may cause sexual dysfunction, sphincter dysfunction, fecal incontinence, urinary hystency, and a foreign body sensation in anus, rectus, urethra, or vagina. Some patients refer with this complaint to me. And you see, this is the pudendal nerve. And fortunately, again, it has the artery. And one of the advantage of ultrasound is that you can see the parts of the artery and you can see the vessel in contrast to fluoroscopy. So when a nerve like this has an artery with it, you can see it easily in ultrasound and find the nerve, because nerves are very small. You couldn't see the nerve, but you can see the artery. And look at here that this is piriformis muscle, and again this is under the piriformis. Between this ligament, sacrotuberous and sacrospinous ligament, these are a good point, and you can find it, and it is a cause of entrapment also. And this case report, I want to open this problem for you. A woman referred to you with complaint of widespread pain, tiredness, fatigue, insomnia for 6 months. She has some physiological problem. And the diagnosis is that this is due to fibromyalgia, and asked her to do exercise. And she did many exercise. After doing many cycling, she referred to you with complaint of pudendal neuralgia. As I told you, cycling is a cause of pudendal neuralgia. And you may think again, no, this is fibromyalgia. No, this is not fibromyalgia. This is because of another thing. This is because of entrapment of this nerve due to cycling. And after a diagnostic block, pain completely relieved. So if you be familiar with this pain syndrome, you can help your patient better. And this is another case, a woman with 8 history of radicular pain, back pain, groin pain, urethral, vaginal pain, rectal pain, referred to you. The point was that pain exacerbated by sitting and limited her ability to drive. Examination showed tenderness by applying pressure to the bilateral cranial area to ischial spine. Ischial spine is a good landmark, anatomic landmark for pudendal nerve. And burning pain accompanied by tingling, improved by lying down or standing. And they find pudendal neuralgia, and it responds to spinal cord stimulator as acunus medullaris. Okay, in refractory case who didn't respond to injection, to pulse RF, to cryo, you can use more invasive procedure and more expensive procedure like a spinal cord stimulator. We haven't it in our country, very limited time. It's very expensive. I didn't use this. It is common in USA and Europe, and they use it. But you have to have a plan. You have to start from less invasive, less expensive procedure, and then step by step to a spinal cord stimulator if you have it in your country. It's available in your country. And this is another patient, a 35 woman, old woman, complaint of pelvic neuropathy resulting in urinary sexual dysfunction, gastrointestinal dysfunction. In pelvic entrapment neuropathy, you may have this because some of this nerve, including pudendal nerve, is motor also and may cause muscle problem. She presents with the diagnosis of interstitial cystitis, and also diagnostic criteria for pudendal neuralgia and persistent genital disorder. Patient underwent implantation of the combined sacral and pudendal nerve neuromodulation. You can see sacral and pudendal nerve neuromodulation. Peripheral neuromodulation is a good response in this patient. Had a good response in this patient. Sometimes you have to use this expensive modality. And sciatic neuropathy. You may hear many things about sciatica, but you may didn't hear too much about sciatic neuropathy as isolated neuropathy. This is not radiculopathy due to disc herniation. Think about this. This patient syndrome caused by pressure of piriformis, maybe due to piriformis syndrome. I had one patient, a young woman with piriformis syndrome, due to malposition of the sciatic nerve from into the piriformis and pressures by the piriformis and cause weakness of the extremity. And this is the nerve that causes weakness, because you know sciatic is motor and sensory. And patient with diabetic mellitus. Diabetic mellitus, we have a syndrome that may cause this problem. And it responds to injection sometimes, although it releases. We have lumbar, maybe due to lumbar plexopathy, maybe due to trauma, maybe due to neoplasm into abdominal region, maybe due to endometriosis. I put a case report about endometriosis and sciatic neuropathy in a group, international pain physician. I thought you studied it. And maybe due to hypertrophic ossification, it causes pseudosciatica, causes leg pain, paresthesia, dysesthesia in sciatic distribution, worse in night, numbness, weakness, sometimes constant pain, and atrophy of the muscle and sensory loss. And the point that you can differentiate it from radiculopathy is that it involves whole of the foot, not segmental, not along L4, L5, L3, okay? And pain with extended period of sitting and twisting. Sciatic neuropathy is one of the most common nerve of the lower extremity that entrapped, and at the level of piriformis muscle, and more common in women. We have tenderness at piriformis muscle, at distal part of the piriformis, as I showed you before. And this is piriformis, this is sciatic nerve. As you remember, here is superior gluteal nerve. Okay, superior gluteal nerve, patient don't refer with this symptom. It's very different. And here is pudendal nerve. Again, use a curve probe for pudendal nerve rod. Found caudal canal. You can draw a line from here to greater trochanter, and here you can find the ischium and greater trochanter. This is subgluteal technique, okay? And you can find sciatic nerve. We have acoustic shadow of greater trochanter, acoustic shadow of ischium, and sciatic nerve is here. Can inject here. Over the last 3 years, there has been a huge increase in medical research investigating characteristic and potential cause of chronic genital pain. This has helped raise awareness among healthcare professionals and patients. We have to increase awareness for patients too. There is still, however, much more work to be done to improve our ability to prevent people from developing chronic pain and to make sure everyone affected by this all too common condition receives swift diagnosis and treatment. And the reference of this material is from my new book. I wish you like it. All of this case, all of this picture are in this new book with question and clinical pair. I completely discussed them. Thank you.
Dr. Helen, thank you very much for that wonderful lecture. Really appreciate you for discussing all the details of those nerves and all the important points that we need to learn from all these issues. And I know this is a very difficult area, and then we struggle with pain. But I have one question for you. This is one common problem that I'm sure a lot of other colleagues of ours is struggling to treat. How do you approach coccygeal pain?
Oh, yes. Coccygeal pain, I talk about entrapment neuropathy. It's not in this part, but for coccygeal pain, I always inject in around sacrococcygeal ligament. Very, very good result. I had a patient with 8 years of the pain, And I put this picture in my Instagram. The student could look at it. There was even, doctor, calcification in sacrococcygeal ligament. And because she complained from 8 years pain without any diagnosis. And it responded very good to injection and hydrodissection in sacrococcygeal ligament. And she's pain-free for about 2 months after injection. And she always cried for me. Yes, for coccydynia, the best approach and the least invasive approach is injection near to sacrococcygeal ligament. And even if they hadn't good result, you can choose caudal block and you can choose impart block. These are in the next step. If your patient complains from visceral neuropathic pain, for example, burning sensation, you can choose impart block. But if your patient complains just pain when sitting, it's better to just inject in sacrococcygeal ligament.
I see. What solution do you usually use for injection?
Yeah, for injection after COVID, I wrote a lecture in Pain Physician Journal about use of dextrose, about use of normal saline. And from that time, I use, even Dr. Machikanti write a review lecture about normal saline after my lecture, because really normal saline is very good. Normal saline has, yes, relief pain. There is many lecture about that analgesic effect of normal saline. I use normal saline and dextrose water, and dextrose water has analgesic effect and local anesthetic. I don't use steroid. Sometimes, in a special case, I use steroid. In lidocaine, dextrose, normal saline is good cocktail. Use it. Yes.
Very good. Thank you so much.
Thank you.
Anybody from the group who would like to ask questions?
Yes. Okay.
Doctor, may I ask? Can you hear me? Sorry.
Yes, I hear you.
Yes. Thank you very much for your wonderful lecture. We are so happy that you were able to lecture for us. Thank you. My question is, how many times do you repeat it, and what is the interval if you need to repeat the injection? Most of the time. Thank you.
A good question. This is depend on your patient. Most of my patients respond just to one injection, and it is enough for their life. Okay, but some patients, if they don't respond to injection, you have to visit your patient after 3 or 4 weeks, because during it need to have a space about 2 weeks for a good response. Okay. After 2 weeks, patient has the best result, 2 weeks or 20 days. So it's better to see your patient after 3 weeks. Maybe it be enough. Maybe, and also I recommend you to don't stop drug medication. Always use medication and gradually disconnect your medication. Okay, because it needs time to relieve neuropathic pain. Neuropathic pain produced during a long time, so it needs a long time to relieve completely. Okay, so if your patient again comes to you with complaint from the pain, you can say to your patient, this block is not dangerous. We can repeat it anytime. I always say to my patient, don't be worried. If this block works for you, I could repeat it. Especially if you don't use a steroid. If you use a steroid, you have not to use the steroid too much, but if you don't use steroid, if you use even normal saline and dextrose, you can repeat your injection even after 2 weeks, no problem. But the repeat after this injection depends on your patient. Sometimes maybe your patient haven't good result, but have a very short time response. If he has a good response to diagnostic block, but it's short, maybe you can use pulse RF at the level of the nerve, or you can use cryo. I always use pulse RF, but almost all of my patients respond to one injection. But the most important point is that you can diagnose the syndrome. Maybe if your patient don't respond to blood, is because your diagnosis is not correct. So be careful about it, okay? If your patient don't respond to your blood, you have to work up your patient because there is overlap in this nerve. Even maybe you need to block other nerve, okay? So be very careful.
Thank you very much, Dr. Helen.
Welcome.
Thank you.
Any more questions from our friends?
Excuse me.
Okay, go ahead, Dr. Sari. Go ahead. Dr. Ischana, Sari, go ahead.
Thank you, Dr. Helen. Thank you, Prof. Yes, thank you, Dr. Helen, for this excellent lecture. Thank you. My question is how to differentiate clinically, how to characterize each one of which one is neuropathic femoral, which one is lateral femoral cutaneous nerve entrapment, femoral neuropathy, how to differentiate it clinically, based on clinically, femoral neuropathy or obturator neuropathy or genitofemoral neuralgia, how to characterize it. Please give me a clue based on your experience. And my second question, and my second question, I'm sorry, this question is out of topic. I just want to know from your experience, Dr. Helen, are you combine physical supplementation and PRP for knee OA or not, and why? Thank you.
Okay, I explain for you the sign and symptom and history taking from the patient. All of this is in my new book. It's better to study it. I put all the clinical pattern to diagnose this syndrome step by step in my book. Okay, you have to read them and memorize them. When a patient comes with sciatic neuropathy, the sign is different from femoral neuropathy. In sciatic neuropathy, patient complain from whole pain in the foot, but in femoral neuropathy, patient is in the inguinal and thigh. Okay, in lateral femoral neuropathy, pain is in the anterior and lateral aspect of the thigh. So you must know the sign and symptom of this patient. You must ask a patient to always, the art of you as a physician is to listen to your patient. If you listen to your patient with his word, you will understand many things. Most of the physicians are tired and don't listen to the patient. Patient comes to clinic and they say this syndrome. No, the art of you is to be a good listener. When you listen to your patient, you will understand many things. Patient tell to you many good points, For example, a patient comes to me with diabetes. It is in my Instagram, and even she undergone spine surgery, but she still complained from the pain, and it was due to lateral femoral cutaneous nerve entrapment, and respond dramatically to the injection. Yes, because I listen to the patient and do a good physical examination. There was tenderness in the site of anterior superior iliac spine. There was pain in lateral thigh, a numbness there. Okay, and I had a patient, I remember it, a good patient with amyotrophic diabetic. He complained from the pain, and it was completely a sciatic neuropathy. It was not due to a spine problem. And you know, amyotrophic diabetes, I discuss it in my book also. Relief gradually. It has a time and it's relief. But if patient complain from pain, severe pain, you can help him with sciatic injection, very simple injection. And your other question, it was about knee, about pulse RF and PRP together, I think.
Physical supplementation, hyaluronic acid, physical supplementation, and PRP. Yes. Are you combine it or not? Are you combining supplementation?
Okay, I didn't use viscous supplement, sorry. Because I prefer PRP. PRP and prolotherapy has a prolonged effect and repair. And another experience of me is I don't combine anything together. I don't combine pulse RF with PRP. I don't combine viscous supplement with PRP with pulse RF. Why we have to do this? I always want to see the result of my work. There was an experience from one of my colleagues who combined all of them together and had the patient complain from severe pain. I don't know why, but my experience, I don't combine anything together. If my patient don't respond to one approach, I choose another approach. Okay. Most of the time, when patient comes to me with knee pain, first time I search for bursitis, for tendonitis, okay, and for neuropathic pain. Always first, I relieve the pain of my patient with injection in tendonitis and bursitis and in nerve. Adductor canal block or saphenous nerve block has promising effect in my patient. Even for neuropathic component of the knee pain, patient refer to you with knee pain and say to you that my knee and my calf are cold. This is a sign that there is some entrapment in nerve of the knee of your nerve of the knee. So a simple hydrodissection helps the patient very good. I put this picture in my Instagram, and I got very good result from this. Then after I relieve the patient pain, then I go to prolotherapy or PRP. This is my experience. Maybe Dr. Jennifer has other experience, but I usually don't combine anything together. You can combine.
Yeah, I think I agree with you. I would go for the more simple injection first.
Yes.
Do a diagnostic injection like lidocaine,
Yes.
and see if that is the exact area of location where you wanted to inject. And if there's a relief, then I go ahead with the solution that I intend to inject. So I think with this approach, we are more focused. And I agree with you that first things first, it has to be the correct diagnosis.
Yes.
Yeah, because a lot of our members, yeah, go ahead.
I had good result from IPAC block for posterior knee pain. It's very simple and very good. For anterior knee pain and medial knee pain, I use adductor canal block and saphenous nerve block. And for posterior knee pain, I use IPAC block with ultrasound, and very good result. My experience.
Yeah, very nice, very good. Yeah.
Thank you. Thank you.
Thank you. Thank you so much.
Welcome. You're welcome.
Okay, so thank you very much for attending our lecture today with Dr. Helen. And Dr. Helen, I will still have something for you to do, so I will email it to you. Okay, so thank you very much. And, you take care, because we have so much things to do. Okay.
Yes, I really didn't sleep good for 3 weeks because of this book. I was revising it and editing it, and finally it finished. And I wish it would be helpful for the student. It's not bad. It's good. It's good.
Yeah.
Excuse me. How to get Dr. Helen's book? Can I buy it from Amazon, or I have to contact Dr. Helen directly for this book?
No, you have to contact directly to my friend, Dr. Jennifer.
No, Dr. Jenik. Okay.
Yeah, Dr. Jenik is a reference of my book in Philippines. You can ask the book from doctor, and I will send them as a group to him to be free shipping, because it's easier for me to send them as a group.
Okay,
and this is very difficult. Sorry, doctor, because you have to post them for students to other city of the Philippines. It's difficult for you, I know, but I thank you because you help them to receive the book with free shipping. Thank you.
But I'm from Jakarta, Indonesia, Dr. Helen, but that's no problem. I will contact Dr. Prof. Jenik Kasar.
No, in Indonesia, Linda Diwani is the reference. You can ask her the book.
Okay.
Yes, Linda, you know, I put it in my post in Facebook. You can find Linda.
Okay,
Linda is
Linda.
nice. Yes, Linda share my previous book also in Indonesia. Many ask this book, my previous book, Safety Recommendation for Ultrasound Guided Spine Injection from Linda.
Yes, I got your
With
book.
Linda.
Yeah.
Yes, yes.
Yeah, and I want the second, and your second book I want to.
Oh, yes.
Thank you.
You're
Yes,
welcome.
contact
Very
Linda.
good. My
Thank you.
pleasure.
Thank you.
My pleasure.
Thank you.
You're welcome.
Okay, thank you very much, Dr. Helen. See, you have so many fans, huh? Thank you, and you take care, and
Thank you
be
for
safe.
inviting
Okay, God bless you. Okay, take care.